Go ahead, David.
Hello, and welcome to today's event, #GriefLiteracy, Join the Movement. My name is David Wright. I'm an Associate Professor of Nursing at the University of Ottawa. This lecture was originally going to take place during Palliative Care Week this past May. When we originally planned this talk to be given to about 50 or so nurses at CNA House in Ottawa, we could not have anticipated the way that our world was going to change and the new ways that grief would manifest in all of our lives. The interest in today's online event has been remarkable. As of this morning, there were more than 400 registrations from across the country. One of our guests, Mary Ellen McDonald, has spent time today doing radio interviews for the CBC about grief literacy. All of this speaks, I think, to the importance and relevance of this topic throughout nursing and beyond. Over the last several weeks, I have a newfound appreciation for the pervasiveness of grief. Even in planning this very event, conversations have involved colleagues sharing their own stories of death and loss, and the ways that these experiences are made more challenging by the pandemic. So today's event is an academic talk, yes, but it is also a reflection on a topic that is deeply personal. Grief is a paradox. It is one of humanity's most universal experiences, and yet when we grieve, we often feel disconnected and alone. And so I hope that wherever you are, and however you may be responding to grief, whether with your patients, with your colleagues, or in your own families, today's event helps us to counter the loneliness and isolation that is too often synonymous with grief. Before we start, I need to say a couple of words about our hub. The Palliative Care and Nursing Ethics Hub was launched in November of 2019, and today is our first public event. We are a group of academics, research trainees, and clinicians who are passionate about nursing knowledge in palliative care and in nursing ethics. I invite you to visit our website, the link is there on the slide, palliativenursingresearch.com, to learn more about some of our activities. So now the fun part. If I could have the next slide. It is my absolute honor to introduce our two invited speakers. Mary Ellen McDonald is a medical anthropologist. Her current research program in palliative care focuses on bereavement, including sociocultural analysis of child death and parental bereavement, grief after assisted dying, and private and public acts of memorialization. She is an associate member of the McGill Institute for Health Sciences Education and program head, Pediatric Palliative Care Research, Montreal Children's Hospital of the McGill University Health Center. She is committed to understanding how social, cultural, and political phenomena intersect to produce and respond to vulnerability within Canadian society. Her main areas of research include oral health, death, dying, and bereavement, and Indigenous well-being. I'm going to point out that when you listen to Mary Ellen's talk, which is about 20 minutes long, you are going to be listening to a pre-recording. This recording was made specifically for today's event in anticipation of possible internet connection issues, which we've all been dealing with in some way, shape, or form. But Mary Ellen is here with us today, and she will be engaging with us live in the discussion period. Our second speaker is Susan Cadell. She is a social work researcher, and her research concerns death, dying, and bereavement, particularly positive outcomes of caregiving and grief. Susan's most recent projects concern the public health model of bereavement support, grief after medical assistance in dying, and tattoos that disrupt, celebrate, or memorialize. Her talk is about 25 minutes, and she will be speaking live. After these two talks, we have reserved about half an hour of discussion. This discussion will be led by Claire Ludwig, a PhD candidate in the School of Nursing at the University of Ottawa. Her doctoral work is focused on patient engagement in research, specifically engaging frail and/or seriously ill patients as knowledge users. During the discussion period, you are invited to pose your questions directly in the chat box. Claire will be including questions from the audience during the discussion section. Lastly, I want to thank the Center for Research on Health and Nursing, which makes all of our hub activities possible. The Center for Research on Health and Nursing is a University of Ottawa research center, and it is co-directed by the Canadian Nurses Association. I cannot emphasize enough how happy we are to be able to work with CNA in this capacity. And we're very lucky today to have Michael Villeneuve, CNA's Chief Executive Officer, join us. So before we move to our two speakers, I will invite him now to say a few words of welcome to you all.
Thanks very much, David, and welcome everybody. I'm so thrilled to see the large numbers, which indicates the level of interest in such an important topic. Let me make a couple of personal comments, and the researchers on the call will have heard all this many times. My first experience with death was with grandparents, probably not unusual, and that set course in me a certain kind of grieving. I watched patients die and wondered how their families managed, and thought a lot about my own grief at the time. Terrible feelings of loss when you lost patients you liked or who'd been with you a long time and so on. So that was a different kind of experience at a professional level. Certainly sending patients from critical care units to operating rooms to have their organs donated was an unusual experience that sort of wrenches the soul. And then my parents died, and that brought it even closer. And it sort of set a different feeling inside me that left me feeling pretty gutted at the time, especially when my mom died, which was 20 years ago, because she was the first parent to die. And then in February 2009, I turned 50, and the next day we had our 25th anniversary, my partner and I, and 4 weeks later he was dead. And I think it was like falling off a cliff or something. I don't even have a language for it. I can talk about it more now than I used to be able to in a sort of more objective way, but it was really very much like the metaphors you've heard, like crawling. I mean, I felt like I really was on the ground. And it took a year to sort of crawl up enough to go back to work. So I was struck by the profound sense of complete loss and not very much help until, this is just a tip if anyone ever needs one. If you have a meltdown in a liquor store on a Tuesday just before Christmas, you can get help actually quite quickly, as I came to find out. And I was on the couch with a therapist the next afternoon. But I had money to pay for that and certain privilege and access and so on. So I don't know really how people manage who are alone, loners, introverts. I'm an introvert, but I'm good alone, but people that aren't good alone. I think we don't understand it very well at all. And we don't pay much attention in terms of providing services for it across society. So flash forward to COVID-19. We all know some of what's gone on, and I can tell you that just as a nurse leader watching across society, I'm pretty concerned about the level of mental health and emotional health issues, and I think a lot of it is grief. It's great sense of loss of many things. One of my board members, young PhD candidate, 32 maybe, that sort of age, real firecracker, francophone young woman from Montreal, went in to volunteer at one of the settings in which 60 people died out of 170 in 3 weeks. 8 of her patients had died the night before the board meeting that I can think of. And she looks haunted, like broken. Some of it is fatigue and horror, but some of it was grief, at losing that many people and not knowing what to do. One of our staff members lost her dad in one of the places in Ottawa where a lot of folks died. And the total experience over 7 weeks or 6 weeks or something of not seeing him in the end was a photograph of his body. And that's the end, it's over. So I think the damaging effects of this have yet to sort of declare themselves in people. And I'm concerned because nurses are with people in their birthing and in their dying and every minute in between. I often think the person who, other than your partner or your kid, who probably touches you or physically touches you, more than any other person in society is likely to be a nurse. So we need to find ways to help people, to be with people in their grieving and their mourning and their loss. And I'm not sure where that is, but I feel like we don't do that very well as a society, and nurses could have a great role. One of the solutions, or one of the strategies, is the Canadian Grief Alliance. And this is a new initiative to me, but I certainly know, because David has exposed me to it, that they have some very interesting ideas around a national strategy for grieving and some money. And so, you know, just especially in the light of COVID-19, to pay some special attention to it. So I urge you to learn about that, as I am. And David, you asked if CNA had signed on, and I don't think we have. So let's talk about that after. I got your message and took it in. So with that, I just want to thank very much my colleagues in the research unit. I have the honor of being the co-director with Wendy at University of Ottawa. And we've had some exciting work together, and the research unit has jumped to help CNA in the COVID period, which was terrific. And David is a wonderful, wonderful colleague. So I appreciate you very much, David, asking me to have this, giving me time to say hello from CNA. I'm glad you're all here. I can't wait to hear the lecture. And with that, I'll turn it back to you, David.
Thank you so much, Mike. So I believe we can start with Mary-Ellen.
To share this work with members and supporters of the Palliative Care and Nursing Ethics Hub at the University of Ottawa, and thanks to the Canadian Nurses Association for hosting this event and making it possible. So I would like to acknowledge the land from which I am speaking at McGill University. The Haudenosaunee and the Anishinaabeg were the original stewards of these lands and waters. I pay my respects to the Kanien'kehá:ka, who continue to care for this land, and I thank the elders past, present, and emerging for their guidance in our shared learning. I've been working in palliative care research since 2002. I started with a focus in pediatric palliative care and quickly was drawn to the experience of grief and bereavement as an area needing more social science reflection. I'm a social scientist, I'm an anthropologist. And I have continued this fascination with and concern for the place of grief in palliative care ever since. Now, I was reflecting on the tone for this talk and wondering if it's too soon to muster an upbeat kind of talk. Now, I was reflecting on the tone for this talk and wondering if it's too soon to muster an upbeat kind of talk in the midst of a global pandemic and certainly the Black Lives Matter movement. However, I don't think we can do this any other way. Susan and I are so inspired and passionate about grief literacy, and we really feel that now is the time to get people on board with a movement towards community-based kindness and compassion. That is not to say at all that people are not deeply suffering from grief and loss right now. They clearly are. The entire backdrop of our lives, locally, nationally, and globally, brings suffering into sharp relief, clearly. And this talk builds on that knowledge and endeavors to open a conversation that starts with and stays grounded in that backdrop. There is so much awfulness in the world right now, but I don't think it's productive to spend our time together going through the misery statistics and dying images that we are all doom scrolling anyway. So what we want to do is pull us upward and forward to contribute to imagining some alterations to our caring landscape. This is a palliative care talk to a palliative care audience. And so I feel it's okay, I'm amongst friends, to dare to criticize my own family, my palliative care family. So please bear with me as I suggest that some parts of our dear profession may need some attention. The development of palliative care has many important advances, obviously, we wouldn't be, celebrating this nursing hub. However, as a service delivery model, as a number of scholars have pointed out, some more gently than others, its development, palliative care's development, has also gone hand in hand with the undevelopment or underdevelopment of communities' capacities and abilities to care for the dying and the grievers. For starters, this image presents what specialist palliative care looks like in the global north, be it Canada or elsewhere in high-income countries. Now, according to Spernswald, after his decades of service to the WHO cancer portfolio, both the hospice approach and the institutionalized medical approach of palliative care has really failed to reach the majority of those who need it, covering only the lucky few through that tiny bit at the pyramid, at the top of the pyramid. Now, this palliative care development has and is happening against a backdrop of an epidemic of social isolation and loneliness. An epidemic that preceded but is exacerbated by COVID-19. Our societies are experiencing more and more social isolation, and we are living in worlds where loneliness is actually killing people. And even before COVID-19, the social isolation was becoming politicized and medicalized as a public health crisis, with the claim that it was causing morbidity and mortality equivalent to smoking 15 cigarettes a day. And in response, the UK created the governmental position for a minister of loneliness. And we can now add to this the world that we've created in which people are dying alone from COVID-19, and a world in which people are also grieving these deaths alone. So while palliative care has clearly made important advances, I don't want to downplay that, in how we're caring for the dying, we need to be self-critical as well. So the professionalization of end-of-life care means that palliative care is primarily orchestrated by professional carers with formalized care plans that rarely include the full range of family caregivers, and especially it doesn't include the extended informal social networks that are involved in care. It has become normal to pathologize the dying, medicalize it, which disaggregates communities at end of life. And we can contrast that to the birthing movement, which has done the exact opposite. When a healthy baby is expected and born, communities mobilize. New parents are encouraged to seek out parenting groups, Facebook groups, informal social supports. People make casseroles. It's socialized to do so, and it begets a model of both formal and informal community care. And we can add to this list of kind of the challenges with how palliative care is now, this economic challenge of supporting specialized healthcare services. Journalist Andre Picard has likened accessing palliative care in Canada to winning the postal code lottery, because, for example, urban postal codes have more access than rural postal codes. And I would add that there's still even a diagnostic lottery, with cancer still getting more reliable access than other dying conditions, such as end-stage kidney failure or COVID-19. And then especially important for this talk is that palliative care seems to have forgotten, I don't want to say entirely, but I kind of feel it really forgets about grief. My epiphany began when I went to my first public health palliative care conference a few years ago in Ottawa, and I've gone to another one since in Australia. So the public health palliative care movement is really challenging conventional palliative care, challenging the notion that death and dying should be housed within clinical and institutionalized contexts, that it must be managed by professionals with increasing specialized expertise. And public health palliative care is also a movement that is supporting efforts to normalize conversations about death and dying by opening dialogue in public, civic spaces, be it in schools or faith organizations or parliament or even grocery stores. And what struck me and has really stayed with me is this one small phrase, the 95% rule. Now, according to Dr. Alan Kelleher, one of the key founders of this movement, people with life-limiting or terminal illness spend only about 5% of their time with medical and hospital or hospice specialists. That is, as much as 95% of their time is being spent with family and friends in their community, in their mosques, in their schools, in their workplaces, in their grocery stores, not engage with medical professionals or resource-intensive service delivery models of care. And yet, with our blinders on and well ensconced in our silos, we, me, the palliative care researcher, tend to focus mainly on this 5%. And of course, this is a rhetorical metric. I don't think anyone did the math to figure out this 95% rule. But regardless, this short phrase is the foundation of thinking about public health palliative care. How dying people are living and dying in their communities. Now, one of the endeavors of public health palliative care has been committed to bringing forth a community-based focus on death and dying. And at one end of the spectrum, this commitment is materialized by and through community engagement activities, such as through death cafes, many people have heard of those, or the Death Over Dinner movement. And this is all kind of framed in what's been called the death positivity movement. So it's promoting positive conversations about death and dying. And on the other end of the spectrum is community development. So not just engagement, but actual development, which more explicitly seeks individual and community change. And an example of this is death literacy. And that's been advanced by Noonan and colleagues in Australia. And it's not just about passive that's my other hat, death education. It's not just passive education. It's defined as a set of knowledge and skills that make it possible to gain access to understand but act upon end-of-life and death care options. Death literacy is mobilized through practice wisdom, that is the embodied experience of community members caring for the dying in their communities and sharing their experiences in order to improve access to the local death system. And while personally I find this construct particularly helpful to think with in this new public health palliative care paradigm, missing for me and many of my colleagues is again this explicit attention to grief. But what is grief? And why should we care? And how should we respond? So my conceptual frame for understanding grief is starting with the body. And that body could be an individual body. It could also be a social body, like a family or a community or a nation. And I've chosen these images with purpose. Grief in these images is being conveyed as ontologically embodied. That is, it's located in individual bodies, but it's also in the relationships among the living and between the living and the dead. So grief is an embodied response to loss, which is clearly multidimensional, and it affects all of life's domains: physical, emotional, behavioral, social, financial, spiritual, political. And if there is a silver lining to this pandemic, and don't get me wrong, I don't think there has to be, we certainly have seen much more public attention to death, dying, and finally, grief. But grief was there before the pandemic and continues throughout in ways completely related to, but also completely unrelated to the pandemic. And I don't have faith that this pandemic is going to make us all death literate or solve grief for us. Take this reflection from a colleague a few weeks ago. This morning, I read of Quebec's 4th death of a PAB, so an elder care aide, in the CHSLD. A father in his 40s here in Montreal. The opposite of grief. What struck me was how unfazed I was. Early on in the pandemic, I cried often. I cried when the first medical person died in Quebec. I cried when the first PAB died. I cried. It was healthy crying. Today, I read the headline and it was like flipping the newspaper on an average day. I read the article and his death may be on my mind. I may chat about it with a family member or a friend, but that's it. I fear that part of our new normal is the normalization of COVID-19 related deaths. The opposite of grief, it feels like an indifference more than a numbness to the news. It's just becoming normal to read of these deaths. Anyway, just wanted to offer that unsettling reflection on a Monday morning. So I've been thinking and writing about the denial of grief for a few years now, and thinking about what is at stake for grievers in the world that doesn't do grief very well. That world, as I've suggested, includes our world of palliative care. I personally believe that grief denial is doing much more harm in our communities than what many have labeled death denial or death taboo. That's a whole other talk. The denial of grief is a social phenomenon that has much at stake for grievers who end up living loss in entrenched social isolation because few people in their social circles know how to open non-judgmental, non-stigmatizing, listening spaces to help hold and support grievers. What's wrong with how we currently do grief? In our current model, the continuum seems to be, on one end, psychologizing grief and expecting psychosocial professionals to deal with it, fix it, or we leave the grievers to care for themselves in communities where the grief is experienced at best as uncomfortable and met with silence or awkward phrases such as, well, at least he died peacefully. And at worst, it's feared as if contagious, and so well-meaning neighbors cross the street to avoid coming in contact, coming too close to the grievers in case they'll catch it. The public health model of bereavement care was published in 2015 by Aoun and colleagues, advancing a conversation about supporting grief in communities. And importantly, this model builds on empirical research that shows that while specialized psychotherapy will always be beneficial for some grievers, especially the 10% high-risk category at the top of our pyramid here, it is not needed by the majority of grievers who can be well served by non-professional, community-based interventions. And there's even some research to suggest that over-treating grief causes harms. And further, what this model really helps us think about is that all people who are grieving, that's 100% of the triangle, benefit from compassion and non-judgmental social support in their communities, by which I mean workplaces and grocery stores. And this piece, the grief-attuned compassion and social support, is not something that our societies are very good at yet. So building on this model, coming from death literacy through to this triangle that I just presented you, we were working with an international team. So that's Susan and I have been working with this team within the International Work Group on Death, Dying, and Bereavement. And we've advanced this concept that we're calling grief literacy. Now, grief literacy starts with a premise that grief is often lived as lonely and isolating. And grief literacy aims to empower everyday citizens, individuals, networks, and communities to understand grief and to be empowered to support one another in it. This support is mobilized through everyday acts of kindness and compassion, including helping those at the top of that pyramid who are high risk and need specialized help to find professional services. And for those in the rest of the pyramid, a salient social response is community-based acknowledgement and validation. That is no longer stigmatizing the grievers and instead opening non-judgmental and supportive listening. So what do we mean by grief literacy? Well, we didn't actually coin this term. It does show up in non-academic internet sites and in actually one unpublished dissertation. But we've really tried to build this theoretical scaffold of sorts to start to give it some more kind of robust structure and a holding frame. So grief literacy lives in the individual in their capacity to access, process, and use knowledge regarding the experience of loss. This capacity is multidimensional. It comprises knowledge to facilitate this understanding and reflection, skills to enable you to act, and values to inspire compassion and care. But an individual is not an island. Ontologically, people are relational beings embedded in sociocultural contexts. And epistemologically, grief literacy is co-produced, it's co-lived, it's co-enacted in communities. Now, as a group of researchers and clinicians, our end game was important to us. That is, through this exercise of building the scaffold, we were searching for a utopia, something we could call a grief literate society. And so we expressly thought about grief and loss as not just about palliative care. Instead, we were more ambitious in our thinking outside of where the kind of the realm of palliative care to include these other kinds of components. So within grief literacy, we're thinking about multiple kinds of loss. So death, yes, but also non-death losses. So grief from divorce, grief from amputation, grief from tooth loss, grief from pet loss. We were thinking about who is experiencing the loss. So there's issues of gender, there's issues of age, like who died. So the relationship to the deceased, again, gender and age comes into this. What was lost? Was it a person? Was it a pet? Was it a possession? Was it an identity? Loss of a homeland for migrants? Loss of a role as a spouse or a parent? We're thinking about when did the death or loss occur? How much time since the death? There's concepts like anticipatory grief. There's also the idea that grief doesn't have a timeline. Decades-old grief can still feel incredibly fresh. Where did the loss occur? The place of the living, surroundings, a relationship to other people. How did the person die or did the loss occur? Was it through war? Was it through more stigmatizing deaths such as suicide or child loss or murder? So at this point in the talk, I'm going to turn this over to Susan, who's going to take us on our bus to this collectively inspired utopia. And she's going to describe for you the visioning exercise we use to develop vignettes that would signal a grief literate society. How would we know if we were grief literate? And to think through some educational and practice implications of this work. So with that, I thank you for your attention, and I will see you shortly in the question period.
Hello, everyone. I'm Susan Cadell. I am taking up the baton from Mary Ellen. I would like to start by acknowledging that I'm on the traditional territory of the Attawandaron, or neutral people, and the Anishinaabe and the Haudenosaunee peoples. I'm here in Kitchener-Waterloo and work at the University of Waterloo. And we here are located on the Haldimand Tract, which was land that was promised to the Six Nations on each side of the Grand River. And elders that I have known have taught me that a land acknowledgement such as the one that I'm making is about relationship. And today, that's particularly important because grief is about relationship. I am a social work researcher, and to give you a very brief idea, grief came to me first, and then I followed that with research. I lost a number of friends in the mid-90s to HIV and AIDS, and so when I undertook research, I undertook research on HIV and AIDS and have been involved in grief research ever since. I too want to thank the organizers and the Canadian Nurses Association and the Nursing Hub for this opportunity. And I also want to thank Mary Ellen for setting the scene so well and for starting us off so beautifully. I also just wanted to mention that the talk, I think this was in the chat, but the talk is being recorded and will be made available for anyone who missed anything or wanted to or couldn't see it properly. The recording will be made available. So I'm going to be talking to you about some grief vignettes. So Mary Ellen described to you the process of how we as an international group defined the concept of grief literacy, and then we decided that we wanted to think about how we would know if we lived in a grief literate society. So how would we know if we were grief literate? And so we designed vignettes. And I am going to present to you a number of vignettes that the international group worked on that have been published, and a number of vignettes that I have worked on alone to reflect COVID-19 and the current pandemic. But first, if I can just go to the next slide, I, as a researcher and practitioner, as a social worker and an educator, just want to take a few brief moments to add a few things about grief, because I never miss the opportunity to talk about grief. I just want to underline that grief is not a disorder, a disease, or a sign of weakness, and that it is, as Mary Ellen referred to, it's an emotional, physical, and spiritual necessity, and that grief is the price that you pay for love. And the only cure for grief is to grieve. I think that these are really important points. Michael, in his opening remarks, made the comment that he didn't have any language for what he was experiencing. And I hope that by having greater grief literacy, that we will all have more language. And so I think adding to the language is really important. Then the next slide is my nod to the notion of complicated grief. Complicated grief is a phrase that gets used a lot, that I am trying to reclaim by saying that all grief is complicated, but is not necessarily complicated grief. It is that there's a diagnostic category that's occurring that's about complicated grief as a diagnosis, but all grief is complicated. It is incredibly individual, and how I grieve is different from how someone else in my family grieves, even if we have experienced the same loss. For instance, you know, a parent dying, both my, you know, my sibling and I will experience that loss differently. It's very individual, and grief is always, always complicated. And I think it's very, very important not to oversimplify it. So the next slide is my dream hashtag. No more 5 stages of grief. The 5 stages of grief were never ever designed about grief. They were designed about people who were dying, and they have taken hold in our society in a way that really oversimplifies the experience. But they really, they're in books, they're in movies, they're in you know, all kinds of places, they're in practice, and I would love to see that us understand that grief is more complicated than stages. So the next slide is a representation of one of our current understandings of grief. The notion of continuing bonds is that we do not, that grief does not end a relationship, that we form a new relationship with the person who has died. And this portrait is the portrait of children that was painted after the child in the carriage at the back had died, and the portrait is thought to have been painted in order to enshrine that child in the family, and continue that bond of the other 4 siblings, the other 4 Farwell children, having this sibling who was no longer alive. And so I think that this is a pictorial representation of the notion that we have bonds that continue. They may change, but that people don't disappear from our lives except in body, but the way that we relate to them continues or changes, and that's totally fine. It's not about detaching. It's about a different kind of relationship. So moving on to the next slide, I'm going to start with one of 4 vignettes that our international group worked on. There are more in the article that we published, that there was an image of it on one of Mary Ellen's slides. And I have just picked a few because I wanted to add in others that were COVID related. So how would we know if we were grief literate? So this utopian vignette is Hassan was forced to leave his dog while escaping from Syria during the Civil War. 5 years later, now living in Sydney, he meets Ida walking her dog. Ida notes Hassan's interest in her dog and invites him to tell his story. Ida recognizes Hassan's grief, invites him to walk the dog with her and teach her more about Syria. So this particular vignette is trying to get at loss due to fleeing a country and acknowledge the importance of pets, and not necessarily needing to have Hassan acknowledge his grief in that he needs to seek help, but maybe he needs a friend and needs to be less isolated, even just someone to walk a dog with. So that is one way, one vignette that would illustrate a grief literate society. And the next slide is another example. How would we know if we were grief literate? Phyllis hires Bill, an Indigenous speaker, to address her class by telling his people's story, focusing on resilience, intergenerational grief, and trauma. The students appreciate hearing the personal side of what is already covered in their assigned textbook. Again, utopian, we are acknowledging that we need to understand Indigenous history. It isn't necessarily taught in all places. And that when we invite people to come into our classes and speak to us, that we need to hire them and pay them. So various ways, various aspects of being grief literate. Next slide is another vignette. How would we know if we were grief literate? Carlos is 12 years old with the anniversary of his twin brother's death approaching. His football teammates are more attentive to Carlos. They notice that, despite the heat, Carlos will only wear long-sleeve jerseys. Worried that Carlos might be self-harming, the teammates approached the coach for advice. We wanted to make sure that that adults and children were in grief literate, and this one demonstrates that the teammates, who presumably are also about the age of 12, are aware of the importance of the anniversary of a death, and so they're paying greater attention to their teammates. And that they are aware of possible things going wrong, like he might be self-harming, and they have a trusted adult that they can go to talk to about that. So it's an example of how we would be grief literate. And the next slide, I saved for last because this is one that met with a lot of appreciative laughter in our international meeting of deaf scholars and practitioners. Jen and Britta have met at a barbecue. Jen asks Britta about her work, and Britta says she is a counselor who works with people bereaved by suicide. Britta is confident that disclosing her work will be met with an affirming response from Jen. Jen responds, "Oh, I've never done that. Tell me more." So this is honestly not an experience that very many of us that I know have had. Anybody who works in grief-related work, and especially with more stigmatized grief like suicide, we don't generally get those kinds of affirming responses. So this was this is sort of the best for last of the published vignettes. And in the next slide, we turn to this pandemic that has happened. So in the next slide is a link to an article in Medium that the group we worked on collectively in terms of sort of translating the notions of grief literacy in the time of COVID, and thinking about ways to normalize what people are experiencing right now, beginning with understanding the grief in ourselves. I think it's really important, and I want to refer back to what Michael said, having no language. I think it's really important that we all have language, and if we start with ourselves and recognize our own experiences, that we can build greater compassion for others and for others' experiences. So this article touches on that a little bit, with the image being of waves, because grief often is described as coming in waves. So the next slide is a series of vignettes that I take full responsibility for. They've not been vetted by the team, so if you have any criticisms, you have to direct them at me. I would love to have feedback, and I do intend to work on the various vignettes with the team, but this is my kind of thinking about them. So these ones are more about the current circumstances. So Marco had just turned 18 and officially become an adult. He was experiencing complications of an injury he had sustained a few months ago, and his family physician advised him they needed to be seen in the emergency department of the hospital. Marco's mother, Anna Maria, accompanied him to the hospital, was not allowed to stay with him due to the pandemic restrictions. She was very upset by this and sought support from a neighbor who kept her company while waiting for news. One of the aspects that I just referred to in terms of normalizing, recognizing in ourselves and understanding our own experience and developing that compassion is also the ability to to recognize and validate people's experiences, not to minimize. So it seems rather minor that Anna Maria has not been able to accompany Marco in the midst of the pandemic where so many other bad things are happening. But for Anna Maria, this is a major event for her because this is what's happening for her right now. And one of my favorite quotes about grief is the worst kind of grief is the grief that's happening to you. So Anna Maria's grief right now is having to leave Marco alone when he has only just turned 18 and not being able to accompany him. She sought and obtained support from her neighbor. The next slide. B died in hospital of COVID-19 alone because of pandemic restrictions. B's son, her primary carer, mostly felt at peace with B's death, despite not being able to be there. The funeral services were held virtually and enormous support was expressed even though people could not gather in person. During moments of guilt that the family may have contributed to B's illness or failed her, the community supported the son by sitting with him virtually. No one tried to talk him out of his feelings because they recognized that he needed to experience them. Again, the only cure for grief is grieving, and sometimes guilt gets mixed up in that, and we need to validate and explain and not necessarily try to talk people out of that, cheer them up, make them feel better. One of the ways that I think about it is as being an expert companion. So when we're grief literate, the community are expert companions for each person and whatever they're experiencing. And the next slide is about Eveline. Eveline had been living with cancer for months and was in hospital. Pre-pandemic, she constantly had a friend or family member by her side. Now Eveline was no longer allowed visitors. In understanding how difficult this was for her network, they were included in family team meetings via video chat. When Eveline could no longer manage it herself, staff would spend several minutes per day at scheduled times to allow her to video chat with family or friends. This, the pandemic, people didn't stop being ill when they had an illness pre-pandemic. They didn't stop being ill, and but the restrictions then would have a big impact on them, and it's really important to recognize that. Again, that's legitimate grief for her network that they're not able to be there, and for her, and so there needs to be ways to try to mitigate that. So that's one way that we would know that we were grief literate. And the next slide. Guido was having great difficulty after his partner died. The two of them had planned that Sam would have made a medical assistance in dying procedure after trying multiple treatments for cancer. Sam had been approved for the procedure, but had not yet set the date when the pandemic hit. Because of the circumstances, MAID was not possible. After much conversation, Guido's friends recognized how difficult this was and recommended a grief counselor who helped Guido through online sessions. So sometimes there are complicating factors, and if you'll remember the pyramid of bereavement support that was in Mary Ellen's talk, there are people who do require professional support, and there can be complicating factors for individuals that mean that a professional is what's needed. And sometimes their community is not enough. They will still benefit from a community that is better able to support them. So that's what this vignette is trying to get at. The next slide. So how do we know for grief literates? Healthcare professionals would all routinely ask people if they had tattoos or were planning any. The professionals would ask people to tell their stories about their images. Now, this is a little bit of a segue. The next slide, the next two slides are pictures of memorial tattoos. Can I go to the next slide? This is a tattoo, and that's a tattoo that are both memorial tattoos. The first one is for a father, and that one is for a father, and the climbing gear is for a son who loved to climb. If you notice, the climbing gear has dates in it. That is the most memorial aspect of either of the tattoos. These are from a project that Mary Ellen and I were both involved in, that was just looking at tattoos that honored people who had died. And many, 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 many of the tattoos didn't look anything like a memorial tattoo, but they all had stories that went behind them. And if you think back to that, the image of the 5 Farwell children and how I talked about continuing bonds, these tattoos are a manifestation of the ongoing relationship with the person who died, whoever that person is. And so in my mind, if we were in a grief literate society, we'd be asking about tattoos, either existing or planned, because they have incredible stories to tell. And sometimes people don't have tattoos, but they still would have the stories to go with them. And just in our study, there were people of all ages. Our oldest participant was in his 80s and got his first tattoo in his 70s. So it's not just the young people that we need to ask about tattoos. So that's another way that we would know that we're grief literate. And to go to the final slide with a grief literacy vignette. The country of Ireland recognized that the population needed a way to acknowledge grief in the pandemic. They launched a campaign to have everyone, #ShineAlight, be it a candle or a porch light, to honor both healthcare workers and those who died. Celebrities recorded songs and messages of support. The president also recorded a message to accompany fireworks in the capital city. This is a way that we would know that we're grief literate. And this is actually a true vignette. Ireland actually did this, and I was very, very impressed with what they did. Next slide, please. So there are so many implications. There are so many aspects. And I think the number one implication of grief literacy is that we collectively need to talk more about grief. Not talking about grief does not make it go away, and it actually makes it harder for people. And one of the myths about grief is that we shouldn't use the name of the person who died. Often, in my experience in research and practice, is that people who are grieving are waiting to hear the name in order to have permission to talk about the person who died. And the worst case scenario is that they won't want to talk that day, and they will say that. So we need to be talking, we need to be educating, we need to be connecting. We need to be asking questions and listening to answers without judgment. And we need to be getting involved locally, professionally, nationally. So, you know, you're doing it, you're here today, and you're doing that. And another way in the next slide that Michael mentioned is getting involved in the National Grief Alliance. There's a link that we will send out to signing on to becoming a signatory to the National Grief Alliance. It's actually a proposal to the federal government to form this alliance. And the more people behind it and the more associations behind it, the better. The US is starting to take up the mantle. Ireland is also talking about getting involved. So we may actually be looking at an international grief alliance, but the more that we collectively are getting involved, the better we are. So in the next slide, I would just say that I would welcome, and one of the slides will have my email address on it. I would welcome feedback about the vignettes, suggestions about the vignettes, if there's something that you thought of that's missing, situations that are missing. I personally love to picture a grief literate society, so the vignettes are a really positive experience for me, and I would love to hear more about those, and hope that we have lots of questions in the question period. So with that, I thank you very much for your time and attention, and I look forward to interacting with you in the question and answer period with Claire and Mary Ellen.
Susan and Mary Ellen, thank you so much for your presentation. I think it's really pushing us to look at grief in a different way, especially as nurses or healthcare professionals, or even in our own lives. So it's an incredibly important topic that we're talking about today, not just professionally, but it's also deeply, deeply personal. And so it gives me great pleasure to be able to moderate today's question period. So we do have the question and answer box open. We've already had a number of questions posed online, but would encourage you to type your questions in. We may not be able to identify specific individuals. I think we're trying to sort of look at different themes, and certainly the questions that we've had come up have really touched on, obviously, COVID, but a number of other issues that we'd really like to hear your views on. Susan, you ended your presentation today looking for suggestions for vignettes, and I think, you know, just having received some of those questions online, I think you're going to get more than you bargained for, perhaps.
That's fine.
One of the things that did come up was really looking at cultural considerations, and although you presented the vignette with Hassan from Syria, just wondering whether Mary Ellen and Susan, whether you can just speak a little bit more about how we can be more sensitive to the cultural differences when talking about grief and literacy. And even, I think, when people are caught between two cultures, you know, I think of our immigrant and refugee populations who may have been distanced from some of their cultural practices and rituals, as well as some of their support networks. So, Mary Ellen, perhaps I can get you to start, and then we'll move over to Susan.
Yes, thank you, Claire. And hi, everyone. It's nice to be here live. This is a great question. It's a question that we have spent a lot of time thinking about. And just this morning, I did 2 interviews on CBC Radio. And after I finished one interview, I got an email from a listener who found my email through McGill and emailed me. And he is from Mexico. And he was commenting on how they do things differently in Mexico, and the kind of the shock being in Montreal. He lives in a suburb in Montreal where he's lived there for 24 years and he's lonely. And he was remarking on when he flies from Mexico back to Montreal, everyone in Mexico is, you know, WhatsApping him and saying, how are you? How was your flight? Are you happy to be home? Whereas nobody in Montreal is actually reaching out to him. And he was just reflecting on that with, you know, from a point of sadness, but also just wanting to better understand that kind of intercultural piece. And I think we have so much to learn from looking outside of ourselves at how other contexts do grief differently. And I think we can certainly look at rural communities and Indigenous communities and learn a lot about how kind of the communalness in some, not to romanticize it, I don't want to do that, but just how in some kind of social contexts, people do it better.
And Susan, do you have any other insight to add to that?
Well, I guess I would add, just we've been, taking a trip to Utopia, and I would add that, the international group that Mary Ellen and I are part of, we have folks from Australia and Germany. There's 3 of us from Canada, Australia, Germany, Hong Kong. I feel like I'm missing one, but
Japan.
The larger group is from all over the world. And they, I've had conversations with a colleague in Brazil about the applicability of this, of grief literacy. And in my utopia, we are workshopping and making it available and tweaking and vignetting or whatever for in many different cultures and the intersections of cultures that you're talking about, Claire. And that we are, understanding how to kind of bring it home for everyone. But I mean, I think that it's and one of the dreams that we have as well is to turn the vignettes into kind of infographics to make them really simple, and that could be easily translatable. And I think the language aspect is so important because, for many, many years, I was on a real crusade that if you weren't saying dying and death, it wasn't okay. And I really have come to a place of working with and respecting other terms that people use. And that, it's not necessarily that they're in denial if they're not saying death and dying, but that those are the terms that they're using, and we can meet there. So I think there's so many ways that we can sort of test this in different communities, and every community is different. And when communities can be really small, sort of, family units, professional associations, and communities can be, large, diverse countries like Canada, and we need to, I'd like to see it, rolled out in different places and see how it holds.
And it's really interesting how you've brought together the idea of community or culture, because there are a number of questions that have been posted around supporting sort of nursing colleagues or healthcare professionals. So that communities that has at the moment seen an enormous amount of grief. And I'm wondering if you can talk a little bit about that, because sometimes as nurses or healthcare professionals, we're sort of grief illiterate. We know so much on an intellectual level, but then when it comes down to it, it's harder to enact that. And I'm wondering if you can speak a little bit about that.
Sure, I'll go first. I think the workplace is a really important place to be thinking about grief literacy, because we spend so much of our lives in the workplace. And I think, COVID-19 is a very particular scenario that we need to be attentive to. But pre-COVID and then post-COVID, we still have to be thinking about just kind of what is normal, what is the normal world that we live in, and how is it not okay? How could we sit in our workplace as nurses, as social workers, as researchers, as academics? How could we sit in our workplace and sketch a vignette that would make us more comfortable? So I think of my own return to work after my mother died. And my dean at the time was so supportive in his own way by just letting me be and not saying, okay, I'm sorry for your loss, but on Thursday I need this report, sort of thing. So if we can reflect back on our own experiences, nurses in a clinical context, nurses in home care, wherever you are working, and think about your work environment and think, if my work environment was grief literate, what vignette could I write about that?
That's a really, really good point. And I think it's this sort of interface between different professions as well. So we have our own, but I'm just wondering about the sort of that, the intersection between other professional groups. And also, we do live in a medicalized culture that values some responses more than others. And actually, we've had a question come up from a chaplain who is head of a compassionate care response team in a school board. So again, you can see a multitude of different professionals in that setting, as well as the children. And she comments that she often feels that pastoral care is considered inferior to the therapeutic response of social work clinicians. And your presentation suggests that the community response is possibly enough for some people. So how do we sort of avoid rushing in that crisis to kind of take charge and medicalize things in many respects?
I think that's a fantastic point. I mean, and Mary Ellen mentioned it, and it was a real aha moment for me that, in thinking about sort of the pyramid of bereavement support, that that only 10% of people actually are at risk of complicated grief, and therefore sort of require professional support. That's an interesting statistic in and of itself, but what really got me is that 100% of people can benefit from better community support, greater ability of their family, their network, their neighbors, their faith community, their workplace to hold them and support them, and everybody benefits from that. So I think it's really I don't know where we enter into it, and we'll probably all enter into it in different places, but that if we are entering into that, disrupting that notion that if you're grieving, you need professional support, you need to be, you need counseling, you need whatever, that we are all able to support one another, and we could do a better job of it, and that some individuals might need some greater assistance than that, but that we will all benefit from being able to support one another. And that the important piece in that is that I benefit from being able to support you, and you benefit from being able to support me and your neighbor and your coworker. And just to go back to the grief and COVID-19, I think it's so big, and for especially for nurses and for that sector, and it's not finished. That right now we have to hold it and hold space for one another, and that graphic that I have with waves, and it will come in waves, and we will all have good days and bad days, and we need to normalize that and have workplaces that that support it, and networks and neighborhoods that support that as well.
Thank you.
Yeah, and I would add to what Susan said that a couple things. One is this being compelled to rush in and medicalize and take charge. In our utopia, grief literate society, there would be this kind of knowledge and capacity in people to help kind of triage the response, so that there are certainly, like, people at the top of the pyramid, they need someone to rush in and take charge and help support from a professional. And we're not saying at all that that's not important, like, not at all. And some people will walk away and hear that, oh, we don't need grief professionals. And that's not at all what this movement is about. It's more about having a more of a capacity in the average citizen to help to make some of that assessment And also the other thing I wanted to add was that COVID-19 is huge. Hold that there, step back and think about the people who were already grieving or who are grieving something new that's happened that has nothing to do with COVID-19. And there can be an emotional reaction to that that says, well, I don't actually have a right to grieve because these other people are dying, that these other people are kind of, you know, ensconced in this pandemic, which is real, and my little piece of grief doesn't count, doesn't matter. I don't have a right to feel it. And that's tragic. That's tragic. And it goes back to what Susan said, whatever grief you're experiencing is real and it's important. And we have to hold all of this at the same time.
And I just think that I've just been monitoring sort of the chats coming in. So, but I think that speaks to working with multiple losses at the moment. And we've had a number of examples through sort of some of the questions that have come in around how best to support communities. There's a panelist here who works with First Nations communities, and you know, we know of the multiple losses, the deaths, both expected and unexpected, and these cumulative losses are really difficult. And also, you know, some of the other communities, like communities where addictions rates are high. We've seen the opioid crisis. And I'm just sort of wondering in the light of those two experiences that have been highlighted in the chat, you know, this notion of multiple loss. And sometimes supporting as well communities like the homeless or other sort of minority or stigmatized communities. How can we best support grief in a multiple loss situation, but also for those that are sort of living with minority stress and stigma?
So I mentioned, it's just this very small question, you know, so thanks.
Sorry.
What time do we have?
But I mentioned that, you know, I came to grief first and did the research after, because I had so many friends die and with HIV and AIDS. And for me, there's a lot of parallels, and there's a lot of parallels, not just for me, you know, I'm in discussions with our local AIDS committee, and, you know, they're seeing it too. And there's a lot of the multiple losses, the stigmatized aspects of it, the possible guilt about transmission. There's a lot of similarities right now, and it absolutely changes people. And there is no question about that. And I have not been reading the chat, but I saw some of it go by, and someone brought up this notion that we live in a society where we need to be positive all the time. And I think one of the pieces of grief literacy is that we all need to understand that it's painful, and that we need to hold space for one another to experience that pain. And today and tomorrow, or now and in half an hour and in an hour and next week and next year. And, you know, for something this large with the, you know, who knows, we're not through the end of it yet. We might be needing to hold this space for a very long time and see it researched, because that's why I've been in discussions with my AIDS committee, because they've come to me and asked if I would be willing to do some counseling with some folks who are actually feeling like that's bringing up the grief from this pandemic is bringing up the grief from those years. So it can raise its head again when we think it's gone away. And so, we need to normalize that and understand that it's painful. And it's not just it's not just positive. There may be positive aspects in it, and there may be ways that people feel supported in their communities, but it doesn't take away the pain. We still need to hold the place for pain.
And I think that's a really, really important point. But in holding that pain, in acknowledging that pain, you know, we've had a question come in about the vicarious trauma for those that are witness to that pain. So I'm wondering, Mary Ellen, whether you could speak to that.
I'm aware that when I'm responding and like thinking about these really important questions, my body wants to sigh. Like, they're heavy. These are heavy questions, and this, you know, this movement that we are trying to start, and we are, you know, trying to think about, it's not going to fix it. Like, you can't fix grief. Like, you know, as Susan said, like there's so much complexity, and it's, you know, these questions and the topics that people are bringing up are really, really heavy. And that's human. That's the world that we live in. So I'm not a clinical psychologist. I'm not going to come at this from that kind of expertise. I'm the anthropologist. I can think back and think about it. But I think at the end of the day, what we're trying to do is make a space for these questions and make a space for these conversations, which is incredibly important. So no, I can't answer your question. Susan, maybe you can.
Well, I would just add that yes, it's making a space for the questions, but it's also, you know, where is it vicarious and where is it not just trauma? Mm. And when nurses are alongside people who are, you know, not able to have their, you know, they're dying alone, that's trauma, not vicarious trauma. Vicarious aspects of it, but you know, I think sometimes we need to name it, and the intersection of trauma and grief, not there for everyone, but it may be very much there in this pandemic, and especially for nurses. And you know, that's a, you know, trauma is a different category. It's a different response. It's a different way of experiencing the world. And you know, you know, I think it's important that we recognize that trauma and traumatic grief is something that people may in fact need to seek help about, which is part of the reason why there's a call for this National Grief Alliance, because in part we recognize that nurses, healthcare workers who are in the midst of this are experiencing such enormous losses that we need to better understand how to support people as professionals as well as communities. So, I mean, that's part of the National Grief Strategy, is a response at a professional level, because there is no question in COVID-19 and that there are areas and sectors where we're crossing the line. We're not talking about grief anymore. We're talking about trauma. We're talking about traumatic grief. And I mean, it's certain, none of it's easy and none of it's 100% positive. It's all painful, but trauma goes beyond that. And we need to have the resources and be able to deliver those resources and support those folks, nurses, you folks.
Absolutely. And just wondering, I mean, there's been a question posed about whether there would be any sort of just would a grief literate society have a day, perhaps like a national date across the country to mourn and grieve?
Yeah, I love that question. And some countries do have kind of a national day of mourning. Remembrance Day was kind of that in Canada, and I can remember growing up and when it was actually a holiday and we were off school and my mother made me sit in front of the TV and think about the war and the people who had died and what had happened. And that was the closest that I kind of had as a child to that kind of that scale. I would love to see, you know, some sort of national acknowledgement, and that's something through this national strategy that we could, you know, think about putting forward. And in that same vein, like, why not public service announcements? And, you know, Susan's big one is like, why isn't it on the side of the bus, you know, or the bus shelter? Like, why isn't it just kind of everywhere that we're thinking about it?
Yeah. And in school curriculums, and you know, we all need to be learning about this.
Absolutely.
I love the idea of a national day, but also, why aren't we able to, you know, when it's the anniversary of my loss, take the day off, and you know, that's not a sick day.
Yeah.
That's a day that I need off of work.
Huge policy implications.
Exactly.
And Susan and Mary Ellen, I hate to have to cut you off here. We have had so many questions flowing in, so if I've seemed a little bit inattentive at times, my apologies. But we are approaching the end of our event now, and I would like to introduce one last speaker, Kath Murray. Kath is a certified hospice palliative care nurse with graduate training in thanatology. She's a former nurse with Victoria Hospice and the Victoria Hospice Palliative Response Team, and for the last 16 years, she has run Life and Death Matters, an education consulting company that she founded with her husband, Ted. She currently sits on the board of directors at the Canadian Hospice Palliative Care Nurses Group, and I will now invite you, Kath, to say a few words to close our event. Thank you.
Was I not muted? Was I muted? I apologize. Do I start again? Mary Ellen's smiling.
Yes,
so,
please, Kath.
Okay, sorry. Grateful to be here and to have heard just such inspiring thoughts about grief literacy. I am so inspired by the palliative care compassionate communities movement, and acknowledge that and acknowledge this. I come and bring greetings today from the Canadian Hospice Palliative Care Nurses Group. And one of the aims of the group is to support nursing research in palliative care, as well as to help support equitable access for all people living with serious illness or life-limiting illness to palliative care, be it specialized or integrated, to educate and support all nurses to integrate and specialize, and to help prepare nurses to write the CNA exam. So a few aims. But I'd like to just do a few, just mention a couple pieces. First of all, I would like to acknowledge and not in a formal sense, but in a very personal sense, the people who have been stewards of the land where Ted and I live and where we work. The Sayote, the Tsartlip, and nearby the Pakwachin and Seacom peoples. And I will integrate that in this story that I'm going to share. Over the years, we've talked about rituals for grievers. For example, that perhaps people that grieve should have a black ribbon or a black arm around their band or something that would acknowledge their grievers. And so today, with a black ribbon on my collar, figuratively, I acknowledge the death of our son, Jordy Murray, who died 5 months ago today in an accident while hunting with some dear friends of his who loved him, doing something he loved to do in nature. One of the comments had been about one of the questions had been about the freedoms to do and care for bodies. And I just want to comment on this. Here I was, a child, introduced to death and dying as a child, as a teenager, as a young adult. Death and grief were part of my life. As a hospice palliative care nurse and as a thanatology, I am well versed in death and in grief, in those basics. But an interesting experience then to have death call once again, but this time for my child. That information helped immensely. We flew to Alberta to bring Jordy home. We flew out the coffin that we had made for my mother 7 years before. We lifted him, we placed him in the coffin. We, together with his dog, drove through the mountains. We got on the ferry, and as we came off the ferry, we were greeted by the First Nation communities. His dear friends had gone out in their trucks to drive their trucks through the mud so they could have muddy trucks. They brought them and they lined them up along the highway with music blaring and their lights on. They greeted us and we pulled over and were hugged by each of these different friends who are family to us. They have helped me to know of and to have seen such grace in the face of multiple loss. My experience helped me to know of the diversity in which we can do things. My experience helped me to know how nice it is that the First Nation people have a prayer meeting the night before the funeral. And in realizing that we have a tradition in our family called the last night on the trail at the end of any major family hike or event, we had a last night on the trail for Jordy, which was a night of song and stories. And again, some of the kids that he had coached in lacrosse came forward and asked if they could drum for him. This knowledge is knowledge that needs to be shared. I so appreciate this whole piece on grief literacy. Yes, about being able to grieve, but yes, about the normalcy of the things and the openness. We knew enough to know we could do pretty well what we wanted, when we wanted, and how we wanted. But that isn't knowledge that many people have. So in closing, I would like to say that I live in family and in community, and I grieve in family and in community. And I am so incredibly grateful for family, for friends, for community who have held us, have sat in silence with us, who have sent me text messages with just blank space in the text message. Little things, big things, marvelous things. And in groups like the Canadian Hospice Palliative Care Nurses Group, I'll just put in another plug. What an amazing opportunity to connect with wonderful nurses from across the country. And I have to acknowledge that David Wright flew out for Jordy's funeral. That kind of acknowledgement of knowing when we hurt, that someone is there to be with us when we hurt. What an incredible gift. What an incredible way for us to live. So grief literacy, utopia. I think within every utopia, there's got to be one person maybe who doesn't get it, which helps keep us sharp and keep us on our toes and pushes us forward. So to the people who don't get it yet, thank you for helping us. Remember to help the rest of us get it and help us to learn how to teach in a way that you too can get it. Thank you. And in the First Nation tradition, Haichka.
Hi, everybody. We have reached the end of our time. I think that it is clear that we could probably fill a lot more space, and maybe we will plan some future events. Kath, I want to say thank you to you so much for honoring us with this story. and for sharing your presence. Thank you to our speakers. Thank you to CNA. Thank you to Claire. You did a masterful job and did not appear distracted at all. And yeah, there's so much more to say, and there isn't time to say it. I think that we all will be calling each other to debrief, and I want to acknowledge and recognize that for many people on the line, today's talk might have brought up some feelings or thoughts that that might be difficult. And if you're feeling inclined to reach out to somebody, it might be an illustration of a grief literate society to do so. So thank you, everybody. Be well. This concludes our event. Take care.
Thank you. Thank you, David.